be here on World Diabetes Day. I thank all of you for being here. I thank Bio-Rad for setting this up and for putting this together. I'm here to talk about the strengths and weaknesses of hemoglobin A1c, especially as applied to the diagnosis of diabetes. And this is me, and you've heard about my introduction. So I live in Atlanta, Georgia, where today and yesterday it was also rainy, cloudy, like it is here in Mexico City. So I'm a little disappointed that I couldn't have gotten a nicer bit of weather, but you can't control the weather, so what are we going to do? I have a disclosure slide. This is where I get to tell you if I have any biases. To bring this talk, you need to know if I have any biases about this subject matter, the various people that are involved in this area, this aspect of clinical laboratory, the diagnostic world, in vitro diagnostics, very important subject matter. And so I want to tell you about my disclosures, what my biases might be. First, I have a bias in favor of good quality. I hope that doesn't offend anybody. Hopefully you're encouraged. And you chemistry students, if you want to know more about the clinical laboratory, what you need to know is that we're very concerned about the patient. The outcome of the patient is the most important item. And so we have to have good quality. So that is my first acknowledged bias I'm going to tell you about. I've also received some honorary and research grants from Becton Dickinson and Thermo Fisher. If you're interested in that, we can talk more about that later. But I'm not going to even mention those two companies again. But I'm here today courtesy of Bio-Rad. I wouldn't be here if they hadn't set this up, if they hadn't paid my expenses and so forth. I don't think that's unusual. As a matter of fact, I don't know anybody in my position who would come and give this talk for nothing and without the cooperation of a company such as Bio-Rad. So this is not unusual, but of course I will be talking about products that in part Bio-Rad is involved in. So you need to know that. I'm also biased about Emory, my university. Grady is my hospital where I work. Grady is the inner city hospital in Atlanta. It's about 900 beds. We have an active clinic, outpatient clinics, very busy place. I'm also biased in favor of my main professional association, and it was already mentioned that I'm a member of AACC. I had the privilege of being a president of AACC back in 2015, so just 3 short years ago. And I'll actually have more to say about that because I want to talk about hemoglobin A1c and the diagnosis of diabetes. And here are our objectives. We're going to talk about how it is useful in the diagnosis of diabetes, how we actually measure it, because we need to know that, to then talk about some of the deficiencies. What are the deficiencies? Well, there are hemoglobin variants that a number of people have and other patient characteristics that might actually influence how we interpret the results. And that issue of accuracy and having good quality means we have to know about these factors. So then we need to know about how hemoglobin A1c is measured so that we can properly apply it in the diagnosis of diabetes. And these, my title is The Strengths and Weaknesses. How it's useful in the diagnosis of diabetes is the strengths. We have some practical information about how we actually measure hemoglobin A1c. And then all of the rest of this is really the weaknesses, the counterpart, the balance that we have to know about regarding hemoglobin A1c. Now, I was finishing this talk just a few weeks ago, and you can see here, where's the date? October 30th, and this was the question of the day, and this is my major professional association. I've told you I'm going to tell you more about it, the AACC. And there's a question every day at that website. And the day that I was finishing this talk, lo and behold, look at this question. According to the recommendations by the American Diabetes Association, diabetes can be diagnosed by which of the following hemoglobin A1c results? And it gives you a variety of choices. Well, that's very intriguing, and hopefully all of you are intrigued about this. And if you want, you can go to the AACC website. You don't have to be a member, aacc.org. And this is a screenshot of my computer. If you go to the AACC website, and you see all these banners up here. You go to Education and Careers, you click on that, you scroll down to about the middle, and that's the question of the day. Every day, there's a new question about laboratory diagnosis, laboratory applications in the clinics, how do we make measurements, some new questions there every day. So I would encourage all of us, but especially you students, challenge yourself with these questions. Well, back to the question of the day on October 30th. What is the right answer? Well, I clicked right there, and sure enough, I got the correct answer. So a single hemoglobin A1c result greater than 6.5 in the presence of clinical symptoms is the right answer. We already heard a little bit about that earlier in the previous talk. So that was interesting. The topics on those questions of the day go from A to Z. But it just so happened that the very day that I was putting the finishing touches on this talk, something popped up that was directly related to this topic. So let's talk about diabetes, and you know about this already, I'm sure, and we heard about this also in the first talk. There's type 1 diabetes, type 2, that is by far the most common. There's other types that are impacted by a variety of different things, such as endocrine diseases, some drug-induced and genetic conditions, and even some infections will produce a diabetic condition. There's also gestational diabetes, and I'll have more to say about that later. And then there's impaired glucose tolerance and, in fact, impaired fasting glucose. These latter two are known to have increased risk for diabetes, but they are not yet classified as diabetes. But if one of us were to find ourselves either in this category or that category, we are definitely at risk for diabetes. We need to take some action ourselves to get more exercise, eat a better diet, and watch out for the other risk factors so we can decrease our tendency towards diabetes. How do we diagnose diabetes? Historically, it's relied very heavily on the measurement of glucose. And we can measure those in a fasting state, that's probably the best. And we can also measure it at any time of the day and disregarding whether we've eaten recently or not. That's called casual blood glucose. And then there are a variety of stress tests, such as the oral glucose tolerance test, which can be used to challenge us as people and then see how our body responds. But it's all relying on measurement of glucose in the blood or in the plasma or the serum that we harvest from the whole blood. There's various problems, though, with glucose. As common as this is, and it is the main way in which we diagnose diabetes, or historically has been, there are problems with that. Ideally, as a patient, you would fast for 8 hours at least. This is easy enough to do if you're going to go see the doctor and get your blood drawn in the morning. Very soon after you wake up, you get dressed, you go out and you visit the doctor or the office or the clinic or the hospital, and you get your blood drawn, and then you can go have breakfast and you're fine. But this is difficult if you got to see your doctor in the middle of the day or in the afternoon. This is tough to do. It's not fun. I don't know how many of you have ever tried it, to do that and properly fast. We need to have nothing by mouth except water. And if you're going to see your doctor at, let's say, 1 o'clock in the afternoon, that means you had to stop eating at night. And then you went to bed, you got up, you didn't have anything, not even a cup of coffee. It's difficult, especially for patients who might have a diabetic tendency. Fasting glucose, and the recommendation is to make a diagnosis of diabetes, you really need to have more than one measurement, more than one time that your glucose was drawn and measured in the laboratory. But there's a significant biological variability going on in all of us as people. The within subject or intra-individual variation is around 5%, and that's just one CV. So if you know anything about statistics, you know that plus and minus 2 standard deviations is 95% of all the data. So that means plus and minus 10%. Your glucose could change by 20% just on a statistical basis alone. So making the diagnosis with 2 different glucose measurements is not as easy as it might seem on the surface. And finally, there's lack of sample stability, depending upon where you went to get your blood drawn, and then where the test is actually performed in the laboratory, in the hospital, in the reference laboratory. Your sample might degrade. There's in vitro glycolysis going on, even in the presence of fluoride. And fluoride has been used historically to try to stabilize the glucose. But I'm going to show you on this next slide that even fluoride doesn't inhibit the glycolysis very well. Now this is in whole blood. It's not been the plasma or the serum has not been separated from the cells, but the data that were published in clinical chemistry about 10 years ago now show that the decrease is fairly significant just within about an hour. So if you're not getting your measurement done in less than an hour, the glucose is going to be dropping. And these are 2 fairly healthy volunteers. You can see on the graph here what the glucose value started out being. It's fairly healthy. If you've got a patient whose glucose is elevated, the impact is going to be even more dramatic. And having fluoride in it helps a little bit, but not a great deal. So that's another issue with glucose. So there's been a progression in the last 15, 20 years as to what we should recommend doctors do to help diagnose diabetes in their patients. This is what was recommended in 1979, all glucose. 1997 it changed a little bit and became more related to symptoms as well. But now in 2018, and ever since about 2009, glucose measurement is really no longer recommended as the sole way in which we should diagnose diabetes. Actually, hemoglobin A1c, and we've mentioned this several times now, can be used to help diagnose diabetes. And it should be confirmed by repeating the measurement on a different day, unless it's pretty obvious. And how is it obvious? You would have clinical symptoms and or glucose itself being pretty elevated. Why is this? Why can we now use hemoglobin A1c to help make a diagnosis of diabetes? Well, it's because the methods are getting better, and there's a lot of improvement in their agreement, their harmonization with all the different methods. So then we can rely on the studies that have been done that show the relationship of hemoglobin A1c to the complications of diabetes, and we can rely on those measurements pretty much no matter what method is being used. You can see when this was first studied, 1993, the variation between all the different methods was huge. And there was actually no method at that point was certified by the National Glycohemoglobin Standardization Program, which is based in Missouri in the United States, but it's now active worldwide, and all the methods, all the vendors who have any interest at all in being accurate and good in what they're doing for hemoglobin A1c need to become certified by the NGSP. But back in 1993, that program was just starting, so there was a hodgepodge of methods, but none of them were certified, none of them therefore were harmonized to come into agreement. That started to change, and by 1999, a good number of those methods are certified, and you can see then that has helped a lot for the agreement between the different methods. But there were still some that were not certified that were way off. That's improved in 01, and certainly by 07, this is in very good shape. And there's still a few holdouts, at least there was about 10 years ago, methods who have chosen not to become NGSP certified. But the commercial pressure on the vendor is to become certified. And I think today, this is really why we can use hemoglobin A1c in our use of diagnosis. And so here's the criteria now that's recommended for diagnosing diabetes. An A1c greater than 6.5. The test should be performed in a laboratory that's using an NGSP certified method, and it's been standardized to the Diabetes Control and Complications Trial, which is 2 ways in which we know if our method is working correctly. There's some alternatives. We can use a fasting plasma glucose greater than 126. In SI units, that's a round number of 7.0. That's why 120, I don't know if you ever thought about why 126. 126 just happens to be a round number in the SI units. And then fasting, again, as I said, is no caloric intake for at least 8 hours. Or you can do a 2-hour postprandial glucose, and that's the value of 200. And finally, in symptoms, a random plasma glucose greater than 200. But the number 1 way is to use A1c and a value greater than 6.5. And so that's what we're going to focus on. As a matter of fact, I took this also on that day in which I was finishing up my talk. I looked at the American Diabetes Association website, and this is what's there about how do you make a diagnosis. The first thing is A1c. You can also use fasting plasma glucose or the oral glucose tolerance test. How about gestational diabetes? That was mentioned in the first talk today. We can diagnose gestational diabetes with standard diabetic criteria such as blood glucose or serum or plasma glucose on at least 2 different occasions. You can also carry out an oral glucose tolerance test, but the cut points are made specific for gestational diabetes. And for that purpose, 75-gram glucose load is recommended. And this doesn't require measuring up to 3 hours. 2 hours is adequate. So you give the glucose load, you measure the glucose, and you stop at 2 hours. And if the glucose is, let's see, greater than 92 as a fasting, or at 1 hour or 2 hour, you can see the numbers here, that would indicate that the woman who's pregnant has, in fact, gestational diabetes. Now, this is recommended to be done between about 24 and 28 weeks of gestation, so well along in the pregnancy. Now, the question might be raised, is hemoglobin A1c useful at all in diagnosing gestational diabetes? Well, the American Diabetes Association, with all of their information, and they come out with a new issue of diabetes care every January, they don't mention hemoglobin A1c at all in gestational diabetes. And the reason is that hemoglobin A1c is a measure of glucose control over about the last 2 to 3 months. In a woman who is pregnant, and we want to do this test at about 24 to 28 weeks, that's at about 6 months. The woman has been pregnant for 6 months. But the blood glucose, if it's going to be high in excess, that has not actually occurred until recently. And that's been studied. It has not gone on for 2 or 3 months, and then we finally detect it. So hemoglobin A1c may in fact not be a good mechanism for diagnosing diabetes in the gestational period, because we want to test it at about 6 months, but the blood glucose has not been out of control since the early stages of pregnancy. It's really been a more recent phenomenon. So for those reasons, hemoglobin A1c probably doesn't work. But there's been a number of studies that have been published recently to try to illustrate more about this. And here is one publication from 2 years ago now. They found that hemoglobin A1c was not accurate in making the diagnosis of gestational diabetes, but it could be used to rule out or to exclude gestational diabetes. In other words, if it was quite low, you could say that woman doesn't have gestational diabetes, because even if the glucose being out of control occurred just in the last couple of weeks, that will influence the hemoglobin A1c at least somewhat. So this study showed that if it was quite low, you could exclude gestational diabetes, and then you would not have to perform an oral glucose tolerance test on those women. And that amounted to about 1/3 of the group that these authors studied. So that's maybe useful. Maybe there is some utility for hemoglobin A1c in investigating gestational diabetes, but you're not going to use it to diagnose it. You're going to use it to maybe avoid the oral glucose tolerance test in about 1/3 of the women. How many of you have ever had the oral glucose tolerance test while you were pregnant? You ladies. Nobody's going to admit to that? Was it pleasant, and did you enjoy it, or was it? It was not very pleasant. I've talked to others like yourselves. So if you can avoid that, that's a big advantage. So hemoglobin A1c, I think, may have that possible role in gestational diabetes. Here's another study that was in the British Medical Journal. They found that the hemoglobin A1c as a screening test did not function nearly as well as the old standard oral glucose tolerance test. So that kind of just supports what I was saying earlier, that to make the diagnosis, we still need the oral glucose tolerance test. And then my own organization, AACC, in that website, if you go to that website, go there every day, every week, every month, you'll see new content all the time. And one of those would be a publication that we used to call Clinical Laboratory Strategies. We don't call it that anymore, but back in April of 2012, that particular month's issue talked about gestational diabetes and whether hemoglobin A1c had any role in making those diagnoses. And unfortunately, the physiology that's going on in the woman while she's pregnant will change things that will influence the hemoglobin A1c measurement, even if there's perfect glucose control, such as increased red cell mass and some other things, will actually increase or influence the hemoglobin A1c values. So it's something to be aware of, be cautious about. And investigators concluded at that time that hemoglobin A1c are not a useful alternative to the oral glucose tolerance test in diagnosing gestational diabetes. And that's because hemoglobin A1c is really a measure of the average glucose that's occurred in the last 2 to 3 months. It's not a measure of glucose control. Here are 3 different subjects that were studied. And I've got the blood glucose here in the traditional gravimetric units. Here they are in the SI units, if that's what you're used to. So here's 3 patients. Patient A, a lot of fluctuation from day to day and from hour to hour, or at least week to week. A lot of fluctuation. But overall, they're pretty in somewhat decent control, and their hemoglobin A1c is going to reflect that. Subject B has the very same hemoglobin A1c, but you can see that this person's glucose control is more reasonable. It's not fluctuating as widely. Subject C has, again, the very same hemoglobin A1c, but this person is in pretty good glucose control, and then they kind of lost it for a while and didn't follow their good diet recommendations and exercise and stress and so forth, and they lost their control, and it was pretty bad up here. All three of these people have the very same hemoglobin A1c because hemoglobin A1c is simply a measure of the average glycemia over the last 2 to 3 months, not a measure of glucose control. What we want, if we're considering gestational diabetes, is to know that the glucose control is either in good shape or it's not, and it's been a recent issue, as I said earlier. So hemoglobin A1c will not be helpful in diagnosing gestational diabetes. It may have a role in detecting the fact that you don't need to go forward with the oral glucose tolerance test, but that's, my conclusion is that's the only role. So now we're going to cover our second objective: how do we actually measure hemoglobin A1c? Currently, there's more than 100 different commercial methods available for measuring hemoglobin A1c. It's one of the largest list of tests and devices out there for any one analyte. It's amazing. And it's a good thing. We've got a lot of different choices. Nearly all methods utilize one or the other feature that of hemoglobin A1c that allows us to measure the hemoglobin A1c, the glycated hemoglobin, free of the other hemoglobins. And those two main features are charge differences or structural differences. And then the four main approaches analytically are ion exchange chromatography, which depends upon the charge differences between the glycated form and the other hemoglobins. Electrophoresis, which is also dependent upon the charge differences and a little bit on structure or size difference. And then there are definite methods that are dependent only on the structural differences. One of those is boronate affinity chromatography, and the other is immunoassay. And there's a new method, newer, which is an enzymatic assay, which also is dependent upon the structural difference. That's an approach that has not been commonly utilized and only has come about in the last couple of years. I'm going to focus on ion exchange chromatography and immunoassay because those are probably the two most dominant techniques that are used. And I'm going to list here for you the advantages and disadvantages of these two approaches. Ion exchange chromatography is capable of measuring hemoglobin A1c, obviously, otherwise we wouldn't be talking about it. But it's also capable of identifying variant hemoglobins, which we're going to talk more about that in a few minutes. It's very important to understand how variant hemoglobins may impact our ability to measure the hemoglobin A1c accurately and with good quality. Remember my bias? Good quality, we want to know, are we measuring hemoglobin A1c adequately and accurately? The ion exchange chromatography approach was that was the approach that was used in most of our clinical trials, including the diabetes control and complications trial, which kind of laid the foundation for the use of hemoglobin A1c in detecting diabetes and determining if the patient was under good control or not. And it's also been used to do this thing called estimated average glucose. You can, instead of measuring your glucose, but that's a snapshot, that's a quick measure of what your glucose is right now. But what we really want to know is what is the average glucose that's been over the last couple of weeks. Well, hemoglobin A1c provides that, but there's been a way to translate that hemoglobin A1c percentage or concentration of that into glucose, and that's what this estimated average glucose approach is. Some disadvantages of ion exchange chromatography are that it separates hemoglobin species based on the charge. That's what we're using to make the measurement. So that's a good thing, but it may not be the correct way in all cases, because you may have different molecules, but they would have the same charge, and then you're going to get interference. So that's something to watch out for and to be aware of. And it's also, therefore, ion exchange chromatography is susceptible to analytical interference from some of those variant hemoglobins, which may migrate exactly at the same spot as hemoglobin A1c or as the total hemoglobin A that we're going to make the calculation based off of. And if that interference is not known, you report an erroneous result, and then we've lost our good quality again, which is not, I don't like that. I've told you that already. How about Amino Turbidimetry? It's very common because it's very easy to measure routinely. This provides good service in general, and there are several, not several, there's a lot of commercial methods available. It's available, Amino Turbidimetry is what is used on a large number of our big automated chemistry instruments that we might have in a core laboratory. But it has its weaknesses. It is unable to identify the variant hemoglobins. You won't know if your patient has a variant hemoglobin, but you may get a hemoglobin A1c result that you report to the doctor, but it's not related to the patient's glucose control. Instead, it's related to the patient's carrying a hemoglobin variant, which is not what we want. Clinically, we want to report the hemoglobin A1c that is related to the patient's glucose control. So we need to know if there's a variant present, and we're not going to learn that typically from immunoturbidimetry measurements. Let's delve into ion exchange chromatography a little bit more. This approach says it uses the charge differences, but it uses cation exchange column, and at different times you flow different solutions through there, different buffer with different ionic strengths, and then that will elute the various molecules of hemoglobin off the column at different times, and then you quantitate those, calculate the percent that the hemoglobin A1c peak is, and then you can determine your hemoglobin A1c. This provides a direct hemoglobin A1c measurement, and it basically has become the gold standard methodology because it was used in a lot of those early trials, and it therefore continues to be the approach analytically that is depended upon to do these clinical trials and relate back to the early clinical trials. It has ability to detect and in many cases separate the hemoglobin variants that we're worried about interfering. So that's a good thing. If we see the variant and it's not right where we're trying to measure the hemoglobin A1c or the total hemoglobin A, that's a good thing. We're not going to have that interference. So, and this also provides information to the doctors about the fact that their patient may in fact have a hemoglobin trait or they're carrying some genetic variant. And they need to know that. Doctors need to know that. It is very common that a number of us in this room might be walking around with a hemoglobin variant, but it doesn't create very much of an issue to our health. We can survive and do just fine. However, when we get our hemoglobin A1c measured, for whatever reason that was caused by, the doctor or we in the laboratory will identify the fact that there is, in fact, a hemoglobin variant. And that may be useful information going forward the rest of our lives as patients and also to the doctor who's trying to take care of us. And so ion exchange chromatography provides that advantage. And as I said earlier, it's directly comparable to the diabetes control and complications trial. And we can use this approach also in order to detect the variants. We can then screen for instance, sickle cell trait and sickle cell disease. which is by far the most common hemoglobin variant. Hemoglobin variants are typically visible by the ion exchange approach, which is good if you want to avoid getting trapped by making a measurement and reporting an erroneous result. I'll show you some data in a little bit. But here's a little bit, a cartoon or a drawing, if you will, of how this works analytically. And you chemistry students may enjoy this. Hopefully we all enjoy it, or all learn a little bit about it. This is our ion exchange column. I'm just showing one side of it, but it's the same on the other side. And here we have a charged surface, and it's negatively charged because it's providing a separation of the molecules based on their cationic charge. It starts with introducing the sample and some buffer, and so they will affix themselves to these charged sites. And we have some hemoglobin that is charged. We have some weakly charged salts that are part of the buffer. We have some weak positively charged hemoglobin fractions that might be, for instance, the hemoglobin A1c. And then we're going to then put a new buffer through here. And then we're going to see some of the weakly charged salts elute from the column and be detected. And here are the kinds of hemoglobins that are going to show up in that first peak. And by a large margin, this is dominated by hemoglobin A1c. These other ones are labile A1c and some other molecules and maybe some abnormal hemoglobins, but for the most part, this peak is hemoglobin A1c itself. Then we bring some more strongly positive charged salts, and we let that flow through the column. That will then kick off the more positively charged hemoglobins, and then they are measured, and they show up here as a peak. And then we're going to, as I said earlier, quantitate the hemoglobin A1c percentage by knowing what that peak is relative to the total, and then we get the percent that is the hemoglobin A1c. So that's how these ion exchange columns work. Now we're going to talk more in detail about the impact of hemoglobin variance on this whole business of using hemoglobin A1c to help make the diagnosis, improve the patient's health by telling whether they're in good glucose control or not. But we need to know these different aspects, these different characteristics of the patient that's going to impact the hemoglobin A1c result. So how do hemoglobin variants and some other patient issues impact the result? There's a variety of issues. The first one is the red blood cell lifespan. And we're going to delve into this in some detail. Then there can be an analytical interference. I've already kind of alluded to this in some of my earlier comments. The patient may, in fact, because they've got a variant, they may not actually have any hemoglobin A, which is our major hemoglobin protein in the hemoglobin chain. But if they've got a variant and it's a homozygous type variant, they don't have any hemoglobin A. But if our method is not able to discern that, we may report out a hemoglobin A1c, but there's no hemoglobin A, so there really can't be any hemoglobin A1c. Are you with me? You're following? Yes, some of you are nodding. That's good. I like this. It's a good audience. All right. So if we don't have any hemoglobin A, but we're reporting a hemoglobin A1c, that violates my quality principle, the bias I have in favor of good quality. I'm emphasizing that numerous times, so you get it. Now, hemoglobin variants, you wish that they were totally uncommon, like we almost never see them. Unfortunately, as I said earlier, there may be people, some of us in the room walking around with hemoglobin variants. It's really quite common. So we need to know the impact of those hemoglobin variants on our measurement of hemoglobin A1c. And then there's also some other patient factors such as aging and genetic and racial heritage. So let's delve into the issue of red blood cell lifespan. If the red blood cell has a shorter life than normal, it's not going to have as much time to bind, the glucose is not going to be bathing that hemoglobin as long, and then have as much of a chance to covalently link to the hemoglobin molecule. So the hemoglobin A1c that we end up measuring is impacted by both the amount of glucose that's circulating in our bloodstream, but also the lifespan of the hemoglobin molecule itself. And if the hemoglobin molecule has a shorter lifespan, we're going to get a falsely low hemoglobin A1c comparatively if the glucose control is the same between two people, and the hemoglobin A1c therefore should be the same, but one of the people has a shortened red blood cell lifespan, their hemoglobin A1c is going to be lower just on the basis of that shorter lifespan, not on the basis of their glucose control. A lot of people don't understand that. Most doctors don't understand that. So we as laboratory professionals need to talk to those clinical people and remind them or tell them about this phenomenon. That hemoglobin A1c, yes, we think it's worth doing, and it largely is, because it's telling the doctor and the patient about whether their glucose control has been good over the last 2 months or so. But if there's a variant hemoglobin, it has a lower lifespan, a shorter red blood cell lifespan, that's going to impact that result, and we need to know that. So shortened red blood cell survival affects this relationship between the glycated hemoglobin that we're trying to measure and the mean plasma glucose that we're trying to detect with this measurement. So hemoglobin A1c values are not just influenced by the glucose, as I've just said, but also by the red blood cell lifespan or their survival. If the red blood cell survival rate goes down, what happens to the hemoglobin A1c? Everything else being equal, goes down, right? If the red blood cell survival rate is elevated for some reason, and I'll give you some reasons in just a minute, what happens to the hemoglobin A1c? Everything else being equal, goes up, right? So the glucose control is not the only thing influencing the hemoglobin A1c that we measure. We need to remember that. Without any change in the glucose control, this phenomenon will occur. And so again, how accurate is our hemoglobin A1c result, and how clinically useful therefore is it? We need to understand that hemoglobin A1c results are influenced by the red blood cell lifespan. And this is in relationship to current guidelines and what we call a high hemoglobin A1c, let's say greater than 6.5. That was helpful to diagnose diabetes in our patients. Well, that could be caused by poor glucose control, but it also could be caused by anything that's lowering the red blood cell turnover. In other words, increasing the red blood cell lifespan, such as iron deficiency, B12 deficiency, or folate deficiency. All of those conditions are examples of where the red blood cell lifespan might be increased because the turnover rate is low. And so that's going to bump up the hemoglobin A1c at this, there's nothing happening with the glucose control. On the other hand, we could have a variety of reasons why the red blood cell turnover rate is higher. In other words, the lifespan of the red blood cell is shortened, and that could be caused by some hemolytic disorder, treatment of these varieties of other things, or hemoglobin variance. So let's look at the hemoglobin variant data that's out there about what is the lifespan. Most of us have the normal hemoglobin, and that's called the wild type. It's out in the wild. That's the term that people have used. And that lifespan is about 120 days. Hemoglobin AS, so we have part A but also part sickle. So this is the sickle trait. That decreases your red blood cell lifespan noticeably. Now it's not huge, it's small, but there's a noticeable drop in that. And this has been published, you can see the data, some was way back to 1943. Hemoglobin AC, that's also the trait of the C molecule, drops it even further. Sickle and beta thal, if you've got that combination, your red blood cell lifespan is quite a bit shorter almost half of what the wild type is. And then if you've got these homozygous combinations, your red blood cell lifespan is really short compared to the normal or the wild type. So that is that's a fact to keep in mind relative to this idea that measuring hemoglobin A1c is wonderful and totally useful. It is, it's pretty good, it's one of the best lab tests that we've got, but we need to keep these issues in mind. So factors that can interfere, the most common variants are these sickle cell trait, hemoglobin E, C, and D. We shouldn't really use hemoglobin A1c for diagnosis or even for monitoring these patients who are homozygous for these, or that have the combination of S and C, because of the impact on the red blood cell lifespan. And we're going to get falsely low hemoglobin A1c results, which is going to maybe indicate to the doctor that their patient is fine, when in fact their glucose control is not very fine at all. Now, you can measure hemoglobin A1c accurately, analytically, for many of our methods. And these have been studied and investigated, and if you go to the NGSP website, you can see that they update a list every time there's a new vendor that comes out with a new hemoglobin A1c method. They update their list. They do the studies. They say this new method has this characteristic and this approach is fine and we agree with it, or we caution you against using it. Whatever, they'll come up with those recommendations. And so you can measure hemoglobin A1c accurately, but if you have a red blood cell lifespan decrease, you're going to get a falsely low hemoglobin A1c value. And then there's hidden dangers. This is a publication that a couple of us at Emory did 4 or 5 years ago. And this really points out what I've been trying to say, both in the lifespan, but also in the fact that analytically you might be able to measure the hemoglobin A1c, but it may not be clinically accurate or helpful at all. So here are some patients that have the SC combination. So they've got sickle trait and the C trait together, and you can see that this was not that uncommon in this study that we did. And then here are 4 different methods that we studied: ion exchange chromatography, 2 immunoassays, and the boronate affinity from Trinity. The Bio-Rad variant is the ion exchange approach, and back then it was the Turbo 2. Now it's, the D100, right? But at that time, we didn't report these values because they were so wacko. They were so high. And something was obviously wrong. And actually, the variant, as I said, the ion exchange approach, can detect the fact that there's variance present. So that's a good thing that we didn't report these erroneous results. These other methods couldn't detect that presence of those abnormal hemoglobins and reported what they thought was, and what the laboratory thought was, an accurate hemoglobin A1c. But notice, they don't really agree that well. Let's just pick this first one here. 4.7 indicates great glucose control. 4.9 is okay. 6.3, that's getting close to, that's not very good glucose control. Might even argue that you're almost going to diagnose diabetes in that person. And that the same is true with all of these. Look at the sickle cell disease people. Same kind of phenomenon. And then the sickle beta thal patients, same kind of issues. Now, we had a case just last July. Patient is a 54-year-old female. This was at Grady Hospital. Has known type 2 diabetes and also has hemoglobin SC disease. So they got the sickle trait and the C trait, which means you've got SC disease. Hemoglobin A1c couldn't be measured because she has no hemoglobin A present. And so it was one of those in that first column on that previous slide. The glucose at that time was 190, so not real bad, not what she would like, not what patients should be with type 2 diabetes, but okay. But the interesting part here was that back on May 21st, her hemoglobin A1c was 5.6%, which looks like great glucose control, right? But her glucoses around that time were nowhere near good control. Matter of fact, this is horrible. She's going to have all those complications that we heard about earlier. So what's going on here? Well, first of all, if you have glucoses in the 350 range, here we are at about 350, and this chart has been around since hemoglobin A1c has been around, and you can see it from 1987, there's a pretty strong relationship between the mean hemoglobin A1c and what your glucose control has been. So if we take this lady who's at around 350, her hemoglobin A1c should be around the high 11s, not 5 or 4 or something like that. So what is going on here? Well, we started using this new method, happens to be the Bio-Rad D100, ion exchange chromatography, on July 18th. So just 6 days later, we encountered this patient. The old method was the boronate affinity method, which I showed you on that hidden dangers chart. Will report a value. It may be analytically accurate, but it is probably not clinically accurate. And our new method uses the ion exchange chromatography approach. It detects the presence of variants, but will largely avoid reporting an erroneous result, which is clinically misleading. So that's what we reported to the clinicians, and I gave a variety of different talks as we were making this transition, because this is changing things in the laboratory as to what the doctors will get from us, and they needed to know about that. But this is just one example of several where the results that we were reporting before were not meeting my bias. Whoops, sorry about that. We're not meeting my bias of good quality. Okay. And variant hemoglobins are very common. There's been over 1,500 of them identified. And if you go to this counter, it's updated almost every week with new variants that have been identified. The estimates are that in the U.S., I didn't find this for Mexico, but in the U.S. there's about 150,000 people at least who have diabetes who also are carrying one of these genetic variants. So the impact of that on hemoglobin A1c measurements is profound. Hemoglobin S and C represent the most common variants, and in our little study I mentioned that we have about 11% of our patients at Grady harboring the S trait, so it's quite common. Now the variant hemoglobins may increase, may decrease, or may not influence, not alter the hemoglobin A1c values. The effect is dependent upon the method that we use and also that issue I mentioned earlier, the red blood cell turnover. So you got to consider a hemoglobin variant whenever an A1c value doesn't correlate the results of either your glucose monitoring results that the patient has been doing, or it doesn't look good compared to a previous result, analogous to that case that I reported from Grady, or it's more than 15%. It would be rare, it's not impossible, but it would be rare for a patient to have a hemoglobin A1c greater than 15%. If you get one of those, you might anticipate that there's a variant that is influencing the analytical result. For patients with variant hemoglobin that alters the red blood cell turnover rate, you got to consider alternate measures of glucose control. There are alternate measurements. Glucose itself, fructosamine, glycated albumin, some of those techniques might be better in this situation. They're just not as well established and not as well studied as hemoglobin A1c has been. So kind of in summary, got a few more slides left yet, but in summary, we deployed a new hemoglobin A1c method on July 18th. There are multiple methods available, so choose your method correctly and know the advantages and disadvantages. Hemoglobin A1c measurements can be affected by a whole lot of different aspects, analytic and clinical from the patient, and you should use alternative markers of glycemic control if hemoglobin A1c is going to be erroneous. Here's kind of an algorithm to use if you think you've got a variant or there's a possible impact of the variant on your measurement. If this is the first time that you're measuring this patient for A1c, ideally you would use HPLC, the ion exchange chromatography, for the initial testing. And what you're trying to do here is to determine if a hemoglobin variant is in fact present. So is there an interfering hemoglobin? If not, you go ahead and you can use any method you want. But if there is one, if the variant hemoglobin detected doesn't interfere with the method that you're using, you can go ahead and continue. But if it does, then you've got to consult with the individual who's responsible for the laboratory. It might be a pathologist, might be a clinical chemist, and then consult with the doctor so that the doctors know what's going on. A little bit on age, race, and hemoglobin A1c values. There's been a lot of publications the last 8-9 years on this. It's a little confusing yet to me, but it looks like there's a definite relationship between your race, your genetic heritage, and your A1c result, and it also increases on your age. So the genetic heritage and your age are influencing hemoglobin A1c at the same glucose level. This kind of blows this up even more. Just know that these data exist, and this is a complicated slide, so I won't dwell on it. But the point is, again, that if your glucose is well controlled, but you're measuring the hemoglobin A1c in a variety of different groups of people, you're going to get different A1cs, even though the glucose control is the same amongst the different people. So what are the limitations again? Analytically, we may not be able to interpret the results with various conditions, so you've got to use assay methods that are immune to these traits. Clinically, you've got to worry about the altered red blood cell turnover. Even if your method analytically produces good results, it may be clinically erroneous. So then you should use glucose-based methods and forget the A1c. And it increases with age and different races as well. So consider a hemoglobin variant. I kind of said this already, but I'm really trying to emphasize this as I close. And so know that this is something that you should consider in the laboratory. Remember that several A1c methods will produce a value even if there's no A1c, no hemoglobin A present. That's not good. And for patients with a variant A1c hemoglobin, you got to choose alternate methods of glucose or glycemia control. So hemoglobin A1c is valuable, but it's just like almost any other lab test. Strengths and weaknesses of every lab test are out. It's got to be used appropriately. It can help with the diagnosis, monitoring, and management of diabetes. For patients with a variant hemoglobin that alters the red blood cell lifespan, you've got to use other markers of average glycemia. And I'm done. Thank you very much. Appreciate your attention.